Now we'll wrap up our topic on adrenal with the last topic, which is Addison's disease. So, what is this? This is basically a primary adrenal insufficiency. So, what happens over here is that the adrenal hormone, specifically the cortisol, is very low. So, in case of primary, there is loss of function of adrenal cortex. Since there is a primary, there would be a secondary adrenal insufficiency. What happens in secondary adrenal insufficiency? There is deficiency of pituitary ACTH secretion. Then, in case of tertiary, there is deficiency of loss of hypothalamic CRH secretion. So, how does such patients of adrenal insufficiency present? They present specifically the chronic form in form of anorexia, nausea, generalized weakness, right? Then there would be acute adrenal insufficiency, which usually presents as shock plus fever, nausea, vomiting, abdominal pain, hypoglycemia, electrolyte imbalance. Now, there is a famous MCQ which has been asked innumerable number of times and is a common repeated question regarding the Waterhouse Friedrich syndrome. So what it is, basically bilateral adrenal infarction plus hemorrhage plus meningococcal sepsis. Infarction plus meningococcal sepsis. Now, so in Addison disease, there is another flowchart which has been mentioned in Saveston. So I would like to discuss you with that. If you have a suspected adrenal insufficiency, so first, what you need to do is measure the 8 a.m. serum or cortisol levels. 8 a.m. serum cortisol or salivary cortisol. Now we check the values. If this values, that is serum cortisol, is less than 15 microgram per deciliter, or the salivary cortisol is less than 5.8 nanogram per milliliter, then you would think that acute adrenal insufficiency is possible. On the other hand, if this serum cortisol is more than 15 microgram per deciliter or salivary cortisol more than 5.8 nanogram liter, then the acute insufficiency is going to be unlikely. So now once this is possible, then we give a 250 microgram ACTH stimulation test and measure after 30 to 60 minutes. So the first step is to check the serum cortisol and the salivary cortisol. If that is low, then there is a possibility of acute adrenal insufficiency. Once that is established, then we give a concentropin ACTH stimulation test and measure the level after 30 to 60 minutes. Now, if post cortisol level is less than 18 microgram per deciliter, or post cortisol level is more than 18 microgram per deciliter. If it is more than 18 microgram per deciliter, adrenal insufficiency unlikely. Now, if it is so, there is adrenal insufficiency. Now, in order to find out whether it is a primary or secondary, the next step would be measure the 8 a.m. serum ACTH. Now, if there is increased ACTH, that means it is a primary adrenal insufficiency. Now, if there is decreased or normal, then it is secondary adrenal insufficiency. So the Addison disease, a primary adrenal insufficiency, whereas there is loss of function of adrenal cortex. Then there are also secondary and tertiary. In secondary there is loss of ACTH, and in tertiary there is loss of CRH. Now the chronic presentation usually would be in form of anorexia, nausea, weakness. The acute adrenal insufficiency would present in form of shock, fever, nausea, vomiting, abdominal pain, hypoglycemic symptoms, and electrolyte imbalance. And then the star MCQ, which has been asked multiple times, is Waterhouse-Friderichsen syndrome, which is bilateral adrenal infarction and meningococcal sepsis. Now, this is a flowchart depicting regarding the establishment of adrenal insufficiency. Such questions would be usually asked in central exam institutes, where if you are suspected adrenal insufficiency, first step is to check the 8 a.m. serum cortisol or salivary cortisol level. Now, if this level is less than 15 or less than 5.8 in case of salivary cortisol, it would be a possibility of acute adrenal insufficiency. Then we will be giving an ACTH stimulation test in form of 250 microgram and measure after 30 to 60 minutes. Now, if that the post-cortisol still remains less than 18 microgram per deciliter, it would be in case of adrenal insufficiency. And if it is more, it is unlikely to be an adrenal insufficiency. Then we measure the 8 a.m. serum ACTH. If there is an increased ACTH, it is going to be a primary adrenal insufficiency. And if it is decreased or normal, it is going to be a secondary adrenal insufficiency. Now, in this, before we end, there is one more question which has been given in a lot of MCQ books. So I would just discuss over here as a one-liner question, which would be your Nelson syndrome. Now, what happens in Nelson syndrome is when an adrenalectomy is done in setting of residual corticotroph adenoma, this tissue predisposes to development of Nelson syndrome. So what happens over here is there is high ACTH levels and there is increased pigmentation. So you will be getting some clinical scenarios for Nelson syndrome. Over here, the most important keyword would be increased pigmentation. So that is all for adrenals. Thank you.